Greetings, everyone, and welcome to this edition of the RGP of Toronto Network webinar. I'm Ken Wong on behalf of the team at the RGP of Toronto, and very pleased to present a double bill today. We have two fifth-year residents in the Geriatric Medicine program at the University of Toronto to talk about two angles on geriatric screening. And I'm quite excited at this topic. I only skimmed through their slides last night as we were putting this together. And I wonder if after this discussion, we may have a better hint on the question of whether to screen or not to screen. I've always found screening very challenging in the geriatric population simply because of the extreme heterogeneity of our patients, their family networks, and that problems tend to be very complex. And I often wonder whether through the process of screening, we are trying to come up with a black and white solution to what is really a very colorful audience. So hopefully this discussion will help us provide some food for thought. Please also contribute to the discussion, and you can do so by opening up the chat box on your computer. That should be on a menu on the bottom bar of your screen. And on the chat box in the bottom left corner, there is a tab. Please set that tab to read all panelists and attendees, and that will ensure that everyone can follow the discussion and contribute to this learning. So our speakers today, first we will have Dr. Katherine Krause. She completed her general internal medicine training at the University of Toronto and med school at the University of Limerick in Ireland. I forgot to ask her to do part of her presentation as a Limerick, but maybe she will treat us to some useful knowledge instead. Her interest in geriatrics dates back to her master's work in geriatric biomechanics at the University of Guelph. And Katherine is a recent recipient of the Esther and Saul Baker Award in Geriatrics from the University Health Network. I'm going to introduce our second speaker as well. She'll be joining in about halfway through the presentation. Dr. Mauli Mehta completed her internal medicine training at Western University and med school at Wayne State University School of Medicine. Dr. Mehta has a 2-year-old daughter, so she is dual trained in geriatrics and pediatrics. And Dr. Mehta tells me that her daughter teaches her to appreciate the small things in life. So now that we know our speakers, let's turn things over to Dr. Krause, and she will lead us through a discussion of screening and triage.
Perfect. Thanks, Ken. So as Ken mentioned, my name's Katie. I'm a PGY5 in geriatrics, and for my section of the presentation today, I'll be taking a brief look and a little bit of a brief tour for everyone through screening and triage, and within geriatric populations specifically. So I have no conflicts of interest to disclose at this time. The outline of my presentation is relatively straightforward. So we're going to go over screening in medicine in general, the importance of screening, and then how it pertains to geriatric medicine or geriatric population. I'll spend a little time describing the difference between screening and triage, because this does come up quite a bit, and it's an important distinction to make. I will also look at triage, its importance in medicine, and then finally finish off on triage in a geriatric population, and selfishly plug in a bit of a project that Dr. Liu and myself are working on currently to get a sense of people's thoughts on it. So first I'm going to start with some questions for the audience just to get a sense of who I'm speaking with and how knowledgeable you are. My first question is about the difference between screening and triage. Do you feel comfortable knowing the difference between those two entities?
And we've brought up a poll. You can click on yes or no. All three questions are displayed there, so you can answer all three yes or no. Question number 1, do you know the difference between screening and triage? Do you think you know the difference? Number 2, do you use a screening tool in your work and practice? And for bonus marks, you may enter in that screening tool and a brief description in the chat box. And number 3, do you use a tool to triage patients in your work or practice? We'll give you another maybe 10 or 15 seconds to vote. I see about a third, coming close to half of the audience have voted. Let's give you 5 more seconds. So this is your last call to vote, and we will close the poll and show results. We're going to give it 3 more seconds. And there are the results.
Perfect. So for my first question, do you know the difference between screening and triage? I'm actually quite happy there was some no's in the audience because this is kind of the big chunk of my presentation that I wanted to relay to the audience. So glad to see that some people will get some good information from this talk. Do you use screening triage? Oh, sorry, I should also say about 66% of you said yes, you know the difference, and 36% said no, you do not, or maybe aren't fully confident in the difference between screening and triage. For my second question, do you use screening tools in your work or practice life? And a vast majority, 73% of you do. And I'm seeing lots of different screening tools like MMSEs and MOCAs, which a lot of us are familiar with. And oh, someone mentioned the AUA, very interesting. We'll talk about that shortly. So that's good. There are screening tools that exist and are very prevalent in the workplace and practice. 73%, 29% said they do not use a screening tool. And the third question, do you use a triage tool of sorts? And 42% of you said yes, you do use a triage tool in your work or other practice. But majority of you, 60%, did say no, you don't. So interesting to see those results. So we'll talk a bit about these things coming up. Okay. So screening, what is it? So the objective of screening is to identify disease in its preclinical state. So the U.S. Commission of Chronic Illness in the early 50s defined it as the presumptive identification of unrecognized diseases or defects by the application of a test, examination, or other procedure that can be applied rapidly. And rapidly is the key here, because if you're screening large populations, you want to be able to do it in an efficient way. In the 1970s, Rose and Baker indicated that in order to determine if screening is beneficial, you have to answer three major questions. The first question is, does earlier treatment improve prognosis? And this is kind of the crux of a screening program, because if you don't have an actual treatment for the disease or some way to improve morbidity or reduce mortality, is there even a role for screening for that disease process? Number two, how valid and repeatable is the screening test? You are going to likely have many different people from different backgrounds doing a screening test or tool, and you want to make sure that it's valid and can be repeated in an ongoing way throughout a population. And then finally, what is the yield of the screening service? Will it yield enough people to make it worthwhile? There are some circumstances where you don't need a high yield for screening tests, and a lot of these examples come in metabolic diseases of newborns, where the actual morbidity and mortality of these diseases is quite significant, so you want to catch those. But for our population, you want to be able to have enough people that are caught by a screening tool in order to have it used efficiently within the health system. So next, now only in the 20th century were some conditions able to be met. So you had to have an appropriate test to screen. It had to be a valid test, and it had to be readily available. And in order to be readily available, it also had to be readily available at a cost that was low enough to be disseminated amongst a large population. Now, these tests aren't intended to be diagnostic. You will get a number of false positives or false negatives, but this really depends on your screening cutoffs that are put in place. For example, in this diagram here, or this picture, you see there's a cutoff for a screening tool at A, and that cutoff will give you a very high sensitivity, meaning you will get a lot of people, or most of the people who have the disease as screening positive, but you will also get a high false positive rate. So a lot of people without the disease will end up being screened positive. If you move your cutoff for a screening test over to example line B, you will get a lower sensitivity but a higher specificity within your screening test. Now, those with suspicious findings are meant to be referred for further diagnosis and necessary treatment. Okay. The earliest known screening test that I could find was actually a mental test for officers drafted and enlisted in the U.S. Army. And they said that it was the earliest known screening program for mental illness, and that the purpose was to, quote, eliminate from the Army at the earliest possible moment those recruits whose defective intelligence would make them a menace to the military organization. So what they developed was two tests. One was called the Army Alpha. The second was the Army Beta. The Army Alpha was for literate individuals, and it was done with 100 to 200 men in one room over a 50-minute period. So it was a very large population that could be repeatably tested. It was a paper and pencil test. They'd ask questions. You'd have to write down the answer. It could be administered rapidly, and they quoted a high degree of validity, which I think was in further reading was a bit suspect at the time, or now anyways. The other test that was used was the Army Beta test, and it was used for those who were illiterate and unable to read questions. An example of this test is on the right bottom corner there, and what they were basically asked to do was identify what was missing within the picture. So this test is actually still around today in the U.S. Army. It's called the Neuropsychiatric Screening Adjunct. It's a paper and pencil test. Obviously, there's been some adaptations and changes and improved validity of the test, but this is the earliest known type of screening that did exist. Now, screening is very commonplace in medicine in these years. So it's particularly in cancer, breast, colon, cervical. A lot of these screening programs are very commonplace, and particularly within our geriatric populations. And there's other metabolic and infectious screening programs in place as well. These programs have led to good health outcomes, so improved detection, early identification, and implementation of treatment, prevention of complications, and then overall improved survival. Obviously, screening does have some limitations, which I previously mentioned in brief in previous slides, but there is some false positives and, again, false negatives. And these false positives could lead to overdiagnosis and possibly over treatment or even over investigation of patients. And this can be seen in some of the discussion around PSA screening and prostate cancer. So the question is kind of what cutoff you use to screen is quite important. So for a geriatric population, certainly a lot of these screening programs for very specific diseases do apply to a geriatric population. And there are other diseases that we see often, such as dementia and also mild cognitive impairment. And Dr. Mehta is going to be spending some time talking about screening in these, so I'm not going to delve into this in any detail, so stay tuned. But do screening tools exist for a geriatric population? In other words, do we have screening tools to determine whether or not someone would be appropriate to see a geriatrician? This is what I was interested in. And standard approaches can improve quality of care and can improve outcomes. And there are quite a few tools that are being developed, and I'll just touch on one of them today, and that's the assessment urgency algorithm. And I saw somebody mentioned it in an earlier slide, so I'm glad you did. So the AUA, or assessment urgency algorithm, is a rapid screening tool for older adults based on 6 domains that guide referrals. So the purpose is to identify community-dwelling older adults who are at risk of loss of independence, who may benefit from a more comprehensive geriatric-focused assessment, or who may be at risk for adverse outcomes. It stratifies older adults into 6 categories. So if you get into category 1 or 2, it's less likely a geriatric consultation is required. If you are category 3, you should consider a referral, and then if you're a 4, 5, or a 6, then you should definitely refer to geriatrics. This screening tool, together with customized referral pathways, helps to prioritize assessments, guide referrals to appropriate services based on risk, and it's used, as far as I know, quite frequently in the southwestern LHIN and also in kind of the central Toronto LHIN as well. It was validated in the emergency department, but it is finding its way into other areas of geriatrics or other areas of healthcare, and that would include physiotherapy clinics, seniors mental health clinics, and as well family health teams. Now, is screening the same as triage? The short answer is no. When screening takes a population and finds those who have the preclinical disease and extracts them for intervention, triage, on the other hand, consists of all people who already have the disease or the need for treatment and organizes them into who needs it first. And these pictures, I think, are a nice way to demonstrate that, where the person who is being screened may not necessarily be identifiable initially, whereas the person who's being triaged, for example, these pregnant ladies, will all need to be delivered at one point in time. It's just determining who's going to be delivered first. So it's a good way to differentiate the two. So triage is an original concept that was focused in mass casualty situations. It comes from the French word tiers. It was originally developed in the 1700s by a surgeon for Napoleon's Imperial Guard. And it was developed originally for sorting surgical patients in battlefield settings and contributed to the organization of care systems for ongoing management of casualties. In the 1900s, triage started emerging more in emergency departments throughout the US, Canada, the UK, and other parts of Europe. And it consisted of brief assessments to determine the time and sequence that a person needed to be seen by a limited resource. And the key here is the limited resource piece. Otherwise, triage is not entirely necessary if everyone can be seen in a very short period of time. The other point to note is that triage is very dynamic, so a person can be adjusted within the time and sequencing through the triage process, and this does happen especially in a geriatric population where you have someone who's independently functioning well at home, but develops pneumonia, gets admitted, has a delirium, and then may go home at a new functional baseline. So this is kind of an example of where their needs would change over time. So for those requiring routine care, triage often takes on a very different purpose. So it's identifying patients who require more urgent assessment, and the goal is reduction of morbidity from the disease. But the common thread, whether it's in mass casualty situations or emergency departments or in routine outpatient clinics, for example, is that it's all dealing with a bottleneck towards a limited resource. So we did a bit of a screen of some programs across Canada to get a sense in geriatric outpatient departments what or if they were using screening tools triage tools to identify which patients needed to be seen at different times, either earlier or those who can wait for routine treatment or management. There's not a lot of literature in this area, or actually none, so this is kind of where a lot of our information came from. There are certainly many homegrown triage tools, and by that I mean tools that have been developed in just certain programs throughout, geriatric programs throughout the country. About a quarter of the people we saw, and there was about 15 programs or sites across Canada that responded to our request for their triage tools. And about 25% of these places did have a specific tool that they had developed within their own organization. Now, the tools varied considerably, and a lot of them did have just identification for only urgent issues, and they gave one or two examples of what an urgent issue would be. Few did have a specific time frame that they wanted those patients to be seen within. A smaller number used an adapted tool from another service or sector, and actually a few of those were screening tools that had been adapted into triage tools for a different purpose. For example, a geriatric outreach screening tool had been adapted into a triage tool for an outpatient geriatric clinic. And then the vast majority of people actually didn't have a formal tool, but used just patient characteristics that had been noted in the referral or clinical judgment to determine the urgency of referrals. And an example of some of the things that were mentioned in the places that didn't have a formal tool was mainly RN, NP, or geriatric reviews of the referrals and getting kind of a gestalt sense of the need for urgent care. And this was all based on what was written in the referral already. There were some places that did contact family physicians if they had additional questions to get a bit more information. Some places did say that if a GP calls, the patient is automatically bumped to the urgent list if that's at the request of the general practitioner. If urgent was indicated anywhere on the referral, then that patient gets urgent status. Or if anywhere there was mention of a recent or recurrent ED visits, this person would be put into a more urgent category. And quite a few of these didn't have, or actually all of the individuals with no formal tool didn't identify specific time frames, but these fluctuated depending on their site and their volumes. So to give an example of a triage tool that we saw, and I'm going to keep these anonymous for now, this is in a site within the downtown core, and they triaged patients in a red, yellow, or no color category, and red being priority or urgent, yellow being non-urgent, and then priority 3 being routine. And I won't read these out loud, and you could just take a look at them. But the priority ones were pretty significant syndromes of suspected delirium or either rapid cognitive or functional decline. And they did call all family physicians for additional information if you fell into the red category. Another example of a triage tool we got, this is actually my favorite, was kind of subdividing people into urgent, non-urgent, or non-urgent day hospital. And there was less examples, so it wasn't all-inclusive, but it gave people a sense of what was considered urgent. But they also gave a standard wait time within their triage guideline. So here comes my plug. So the project that Dr. Liu and I are starting now is to try and create the first ever Canada-wide expert consensus administrative triage tool for prioritization of patients in a geriatric outpatient clinic. We're hoping that this tool can expedite services to highly vulnerable older adults and ultimately reduce the burden on acute care centers and emergency departments. What our projected plan is to get a sense of how many geriatricians across Canada would like to be involved as participants. And we've actually gotten approval for our REB and sent out our initial request for participation. And we've had a very positive results so far. It's only been about 12 hours since I sent that email, but a lot of geriatricians are interested in being involved in this tool, so it's great. We'll be using a modified Delphi technique to do this, and basically what that is a process to find consensus among experts who may have differing views or perspectives, and it enables group problem solving using an interactive process of discussion, feedback, and revisions to ultimately create a final tool that can be disseminated across centers to help with triage of patients. So I'll leave you with my final questions. The first one being, do you think a triage tool in geriatric outpatient clinics is necessary? And as a kind of an extension of that, if you were to pick some patient characteristics that you would consider urgent within this triage tool, what would you pick? Now I will give you these in a moment. I see that a lot of people think, yes, triage in geriatric outpatient clinics is necessary. That's good to hear.
Well, a lot of you have voted, and I think you'll be intrigued to see the results. We'll give you about 5 more seconds to vote, and we'll show you the outcome. So 2 more seconds. Well, look at this.
All right. A rounded 100% think that yes, a triage tool in geriatric outpatient clinics is necessary. So great to hear that. That I'm not doing this for in vain. But there are 2 people that think no. So we'll talk after.
Yeah, and we won't name names. Okay, we have a second poll here.
Perfect. So these are just examples. I've kind of put in a mishmash of different urgent patient characteristics that have been mentioned in tools that we've seen. And just curious on your thoughts. You can pick all that apply. Any of these things you think should be considered within a triage tool as urgent. There may be more than this. And if you think there's definitely other, feel free to just comment other and mention what characteristic you think would be really important to include. It's quite an interesting poll for myself because it gives us a little bit of information about what people consider important.
So we'll give you, there's a lot of reading on this poll. We'll give you maybe another 15 seconds to put in your votes. And remember, you can check all that apply. So you can check multiple times. I'll give you 10 more seconds. We've got about a wee bit under a half.
Someone said they missed the instructions for the poll. Feel free to click as many of the options that you believe apply. The question I'm asking is, in your opinion, which of these patient characteristics would be considered urgent within a triage tool for outpatient geriatrics? If you think there are other things, feel free to comment other and mention what those other characteristics would be.
Great. So another 5 seconds, we'll close the poll. About 90 of, just about 100 of you have answered. Our apologies for those. I think a few of you aren't seeing the window, and we will have to investigate that with our tech support team. So here are the results.
Great. So of the options that I gave, so the vast majority of you think risk to self or others for sure should be considered urgent, definitely. The next would be rapid functional decline of less than 6 months. 88% believe that should be considered urgent. Rapid cognitive decline, 86%. Imminent admission or recurrent ED visits, 81%. Active delirium, 79%. Frequent falls, 76%. Responsive behavior, 72%. Caregiver burnout, 58%. And documented urgent by primary care provider, 51%. And then perioperative assessment, 20%. So that's great. That's interesting.
So again, we apologize. There's a small number of you who aren't seeing those poll results. Katherine did read them out, and just as a reminder, we are recording this, and we'll send out a recording so you can view this later and hear the results there.
Great, so that's the end of my presentation. So we can, I guess, take more questions after Dr. Mehta's presentation about mine or hers.
Well, in the meantime, are there any questions for Dr. Krause?
I did see one actually. Can MPs for outpatient geriatric clinics be involved in the study? We've received a lot of interest actually in other geriatric FRCPC specialists being involved, and I think it's really important. Unfortunately, now our REB only covers active geriatricians, but I think this may be expanded in the future because there's a lot of interest, and certainly I see that there is a lot of nurse practitioners and other specialties are involved in the triage process, so it's really good to have their opinion as well.
Great. So there will be more opportunity to ask Dr. Krause some questions. We're just going to transition here to Dr. Mehta, Dr. Mauli Mehta. And again, I'm going to repeat, we're getting quite a bit of feedback that people were all seeing 0 on that last poll. So what we'll do is we will summarize the results by text and send them to you. It is very helpful and interesting information, and over 100 of you responded. We'll summarize that by text and email that to you along with the evaluation link afterwards, so you don't miss out on the results. Again, there's a technical thing that we'll have to investigate on that. So if you bear in mind, through the wonders of technology, Dr. Mehta is at her clinic. She's presenting this webinar practically on the fly as she's between 2 clinical practices right now, but she is at a remote site, and we are just going to test her audio. So Dr. Mehta, can you talk to us? And we want to make sure the audience is hearing you loud and clear.
Yeah, can you hear me?
We can hear you, and I'm about to give you controls for the keypad. And at that point, I will retreat into my cave and allow Dr. Mehta to carry on with the rest of the presentation. This is on screening in mild cognitive impairment and dementia. You know, just before I go into my cave, I tied the President of the United States in MoCA scores. I also scored a 30, and you know, I've never referred to myself as a genius. So perhaps with some of the information you present, Dr. Mehta, we can discuss if that's a sign of altered thinking. Over to you.
Okay, thank you. Hello, everybody. My name is Mauli. I'm one of the PGY5 residents at University of Toronto. So just give me a second to get good control of the screen. Okay, perfect. So I don't have any conflicts of interest either, and my presentation is going to be on screening in dementia and MCI. So I'll be talking a little bit about dementia and MCI, and then applying the screening principles to both dementia and MCI, and then talking a little bit about the current recommendations. Dementia now subsides, so DSM-5 now subsumes dementia under major neurocognitive disorder. And essentially it's a cognitive decline that is significant enough to interfere with independence in instrumental activities of daily living. The major dementia syndromes, as we all know, are Alzheimer's, vascular dementia, frontotemporal dementia, dementia with Lewy bodies, Parkinson's disease, and dementia of mixed etiology. There's, of course, many more other causes, but these are the major dementia syndromes. MCI, the DSM-5 classifies in mild neurocognitive disorder now. The cognitive impairment that's not severe enough to interfere with independence in daily life. And this can be evidenced by the patient themselves, clinician report. You may see impairment in objective cognitive tasks or evidence of decline over time in these objective tasks. Naturally, you would expect dementia to be irreversible and usually progressive. You see early stages, you note changes in the IADLs, like I mentioned, ability to learn and retain new information. And then as dementia progresses, start noticing changes in basic ADLs. The onset and progression have been highly variable, and this depends on the etiology and type, which makes screening difficult as well. MCI, again, may have some clinical utility for predicting later dementia, but a lot of the studies are very variable in the rates that they report for stability, progression, and regression, and part of this may reflect a complex underlying pathology. Can you hear me better now? Thanks. The rationale for, sorry, my slides are going pretty fast. Is there, can I give the control back to you?
Yes, you may. Are you on the right slide now?
No, the slide prior to this one.
How's that?
That's perfect. Okay, thank you. So The rationale for screening in older adults, and there's starting to be more talk about this because we have a rapidly growing population at risk of dementia. There might be some pharmaceutical agents for treatment of dementia now, and others being studied, and the growing potential for research, and also media attention. We also know that about 29 to 76% of patients with dementia or probable dementia are not diagnosed by primary care physicians, and the sensitivity of clinician diagnosis appears to be strongly related to the dementia severity. And so a lot of these patients get diagnosed at the moderate to severe state. And ideally, we want to pick them up earlier. What are some of the benefits of early detection? Obviously, social benefits. You have the need to know for the patient themselves. Also, financial and social planning, knowing that you have MCR dementia early on, can get started on the power of attorney planning, any advanced directives, but more importantly, the safety aspects of it as well. The driving, which is very important, medication management, thinking about blister packs early on, getting family involved, and then cooking and other safety concerns. And more importantly, like the poll suggested, caregiver burden is a major factor, and so early education may help with that and may help manage that earlier on. Other benefits might be, definitely medical benefits, so management of comorbid conditions, consenting patients, so if they're going for surgery, knowing if they have dementia or MCI may be helpful, medication management, and then also treatment modifications. Treating any reversible causes early on, any risk factor management, compliance strategies provided to the patient, initiation of treatment early, and then crisis avoidance, which is important. There are, of course, barriers to earlier detection, and one of the biggest barriers is really time restrictions. There isn't enough time maybe to administer these tests on all the patients, and so how do we pick and choose who to screen? The psychological effects and workup for false positives, and of course the adverse effects associated from labeling. So Katie Krause, Dr. Krause mentioned this earlier, but I'm just going to apply these to dementia and MCI. So just the screening principles, screening test must, in order to have screening tests or to do screening, the condition must be common. You must have sensitive and specific tests that are available for detection. And once you do detect, there must be efficacious treatment with better outcomes on those patients that are treated than untreated. And the benefits of screening must outweigh the harms. So yes, dementia is common. We know, according to Alzheimer's Society statistics, 500,000 Canadians are living with dementia, and 25,000 new cases diagnosed every year. And prevalence is strongly associated with age, or increasing with age. So you have about 0.8% mean prevalence in the United States and Canada at the 60 to 64, and then this increases to 30% over the age of 85. And one study one meta-analysis looked at 35 separate studies on MCI and reported a mean prevalence of about 26%. So it is definitely common. And are there sensitive and specific tests? The basic purpose really is to indicate likelihood of genuine cognitive impairment, at least in the setting of MCI and dementia. So the screening tools must be sensitive, specific, they must have high positive predictive value, must be easy to administer, and must be achievable in a minimal time possible in order to prevent those barriers from becoming a major issue. And we must be able to obtain indices of key cognitive domains in that brief consultation. The problems encountered often with these screening tests is the overemphasis on the memory function, which tends to neglect other domains that might be important for non-Alzheimer's dementia. And this becomes a problem when you're trying to find one screening test. And emphasis on cutoff scores really, rather than profiles of impairment, which a lot of the clinicians like or prefer. JAMA Internal Medicine, a systematic review and meta-analysis was published in 2015, which looked at cognitive tests to detect dementia. This was a study of 140, so they did a meta-analysis systematic review of 149 studies, and they assessed the accuracy of MMSE and to 10 other screening tests for the detection of dementia. They included patients with different types of dementia in different clinical and community settings. They screened patients or caregivers with a face-to-face interview. You had to have a standard diagnostic criteria to define dementia, and they had to report the specificity, sensitivity, and of these screening tests. They excluded patients they excluded studies that were not written in English or that took longer than 20 minutes to administer. So this table 1 from the JAMA article just gives you a sense of the 11 tests that they looked at. So the first column indicates the total score, and then the number of questions and the components of screening tests that the screening test includes. Just moving to the next slide. The most common screening test they found was the MMSE, which was used, about 68%, followed by the MoCA. And patients were mainly from the community and clinic setting, about 80%. For MCI specifically, the MMSE had a sensitivity about 0.62 and a specificity of 0.87, whereas the MoCA was slightly better at 0.89 for MCI. So they pointed out, screening test, the table 3, which includes the meta-analysis for diagnostic accuracy of dementia. And I've highlighted some of the ones that stand out, which is the mini-cog test, the MIS, the memory impairment screen, the GPCOG, which general practitioner assessment of cognition test, and the ACER. Which have a high positive predictive value. They further did a forest plot for mini-cog and ACER for dementia and MoCA for MCI. And overall, what they found is the mini-cog test and the ACER had better diagnostic performance for dementia when compared to MMSE, and the MoCA had better diagnostic performance for MCI compared to MMSE. So the take-home point here is really there's no one perfect test to do for dementia and or MCI. And so I was just wondering what screening tests are used in your clinic, and a lot of you responded earlier on with the MoCA, MMSE, and others. If anybody else would like to respond, please use the chat box to do so. I'm just going to screen through the chat box to see if there's any questions.
Yes, and I'll help guide us through the questions. There were a couple earlier on, and these questions are open game for either Dr. Mehta and Dr. Krause related to screening in relation to triage and for cognitive impairment. Question from Deborah Harmer from West Haldimand Hospital. Is there anybody working on a standardized triage tool for eMERGE? Before we address that, I'd like to invite all of you to submit your questions by writing in the chat box. And just remember to set that box to all panelists and attendees in the bottom left corner. And also invite you to submit answers to any of the questions so we can engage fully in discussion. So again, Debbie's question, a standardized triage for eMERGE.
Yeah, so as far as I know, I don't know anyone who's actually published any standardized triage tools for eMERGE. But there certainly could be people that are working on it, or something I haven't identified myself. So if you do know of one, feel free to comment in the box and let me know about it, because the more I hear of, the better. Yeah, certainly a very important area for ED assessments is triage, because as we all know, a large portion of patients that go through triage in ED departments will be over the age of 65. So a really important place to get additional information.
And Tracy indicates that they're using standard CTAS urgency for triage, but will be implementing the AUA that that Dr. Krause had mentioned. From Jane in Waterloo, Jane McKinnon-Wilson, are memory clinics impacting the percentage with regard to primary care physician diagnosis and early detection? Memory clinics. So maybe we'll come back to that. We have many people submitting their answers using the MoCA, the Geriatric Depression Scale, the SAMIO, the Seniors Alcohol Misuse Indicator, and the GMAST. Others are using the RUDAS, substance use. We'll address that in a little while. MMSE, mini-COGS, the RUDAS scale as well. Mini-COGS are coming up a lot, and the MoCA. Dr. Liu has answered the question on funding for physicians. OHIP requiring that a billing for neurocog assessment is for 20 minutes of testing, and that fits within the OHIP formula. Others use the Geriatric Depression Scale in conjunction with the MMSE and MoCA. And a question on technology. What format do people prefer for triage? I think we can all chip in on that question.
I think for myself, if we do develop a triage tool, there probably will be a paper pencil format, but in the digital age, I suspect an app will come shortly after. There is actually, and I forgot to mention, a nice app for the AUA screening tool that you can actually download if you just search InterRAI, R-A-I, and it's actually very user-friendly, great interface, very helpful.
Right, so again, more of the MMSE and MoCA, SIGI CAPS, CTAS as well in their ED, and looking at trying out the AUA app. Now, without hijacking this question, I know Dr. Mehta has more results to show us, so I think I'll redirect our attention to her.
Okay, yeah. Can you hear me? So just going back a few slides. So is there efficacious treatment available if we do screen these patients? And not to spend too much time on this, but we know that hello? I can't see the screen anymore, sorry. Hello?
And our apologies again. I think there was an internet hiccup that made us lose our screen, but we should be recovered now, and hopefully we can continue.
Okay. So I'll probably just ask you to move the slides then.
Is everyone seeing the screen again? The slide presentation with the forest plots? Good. Dr. Mehta, I think you have the con again.
Okay. I think you still have control. Okay, perfect.
Looking good?
Yeah, I just need to get back a few slides. Yeah. Sorry about that. So there must be efficacious treatment available, and there have been meta-analysis that have been done looking at cholinesterase inhibitors and memantine, and they've used the ADAS-COG and MMSE. And the results really, yes, indicate some statistical significant results, but clinically marginal differences in cognition and global functioning. So not really sure if this would, whether it's really clinically meaningful. It is statistically meaningful, but not clinically. And so what also becomes important are the adverse events. If these patients are taking these medications, are they tolerating it? Or do they have to stop these medications? And this forest plot that you see shows a meta-analysis of cholinesterase inhibitors and memantine on adverse effects. Again, the results indicate that there are side effects and harms that are quite common with these drugs, and discontinuation is more common than placebo. So my next slide is on meta-analysis for psychoeducational caregiver interventions. And like I mentioned earlier, one of the benefits of early screening is probably to decrease caregiver burden. And so this meta-analysis basically was done on patients with dementia, and they provided education to caregivers. Unfortunately, all the trials were not standardized and were variable, but you can see that overall the effect sizes for caregiver burden was generally small, and statistically significant benefit over 3 to 18 months, but a small benefit nonetheless. And similarly for caregiver depression, interventions did not show very significant results, very small changes noted. And so when we review the screening principles, again, yes, dementia is common. There are sensitive and specific tests available for detection, not standard not standard across the board, and some better for MCI, some better for dementia. There's efficacious treatment. It's unclear at this time whether the treatment is efficacious, whether it's better than those patients that are not treated, and unclear whether the benefits actually outweigh the harms. And so the USPSTF states that there's not enough evidence right now to screen for cognitive impairment, but they also state that clinicians should remain alert for early signs of cognitive impairment and evaluate as appropriate. And similarly, for Canada consensus guidelines, there's no evidence for or against. But I was looking through the Alzheimer's disease website, and there's this dementia screening indicator tool, which may help guide clinician decisions or whether it's appropriate to screen or not. So this would be in a primary care setting. Again, this may favor the Alzheimer's disease patients, but something quick to go through, about 7 questions, which may guide whether to use another screening test further. So some thoughts I had would be to potentially screen patients when family members are concerned, of course, when the person is concerned, if you've noticed any changes in their cognition, but also age as potential guidelines. So we know that prevalence increases with age, and probably using an age of 80 or even lower cutoff to try and screen. And the other risk factors might be history of type 2 diabetes, stroke, etc., and then referring to a specialist if needed. There is this, I know earlier there's somebody that mentioned app-based tool. So this is recently on the Toronto Star, a new integrated cognitive test that Cognitivity Neurosciences is waiting approval from Health Canada for. And this would be an app-based test. It's waiting clinical validation studies, but it's about 5 steps and involves using images to assess patients' short-term memory, and may help screen for dementia early if this does work out. But again, there's obviously biases for patients that are able to use the app or use the phone, and so there's going to be issues with it, but may be helpful in the future. So at this point, there's really unclear evidence demonstrating that screening does improve health outcomes. It's not recommended at this time, but if age is the biggest risk factor, then in the future, using maybe that is a reasonable strategy. And I'll welcome any questions for both myself and Dr. Krause.
So the picture of the microphone is the open mic, and the mic being your chat box. You're welcome to ask any questions of Dr. Krause and Mehta's. It's a very interesting presentation, almost unsatisfying that the screens aren't recommended for use. And what I worry about, wonder if you could comment on, is the use of these screens like the Mini Mental and MoCA for like service provisions with agency that, you qualify for such and such if you score such and such a score. Would either of you want to comment on that?
Yeah, so I mean, unfortunately, with the MoCA and MCI, really depends on your level of education, a lot of the other factors that may bias the score. And so somebody with a high level of education can probably easily score 30 despite having cognitive impairment functionally, where somebody with a lower level of education would not. And so I think that's where it becomes tricky to use these screening tests and the scoring really to judge and diagnose.
Oh yeah, it could lead to discrimination of a sort. We have a question from Kimberly. Can you please review or perhaps give your educated guest opinion on the best recommended screening tool for MCI and for dementia, for either Dr. Krause or Mehta?
Yeah, so sure. Do you want to start, or?
Oh, you can answer that one.
Yeah, we're both live.
So, okay. So on the JAMA article for MCI, they recommend MoCA being a better screening test. For dementia, because of time constraints and such factors, the mini-cog they recommended the ACE-R, which is the Adam Brooks Cognitive Examination Revised Test.
So the mini-cog. Angela asks us, are we seeing our OT colleagues being involved to assist with triage? So a triage question, having interprofessional staff help to free up the MD time.
Yeah, so that did come up in a couple of the institutions where they didn't have a formal triage tool. They kind of used a variety of the clinical team depending on what they had available at what site. So a lot of nurse practitioners, if there were nurses with specialization in geriatrics. I didn't actually see any that specified OTs being the ones doing the triage, but it's certainly a person that would be very informed about the needs. Yeah, a lot of the time it was the geriatricians who were doing most of kind of the gestalt assessment and determination of triage if the person's urgent, non-urgent, or routine. So a little bit of a mixed bag.
And I see Sylvia, this relates to that, reminds us that, the more we search for evidence, sometimes the more confused things get, even with practices we've been doing a long time. So a loud reminder that we need to constantly be critical and use our active minds and see the whole picture rather than relying on tools for our practice. I know we've rounded the hour. Are there any, we could stay a few more minutes if there are some burning questions or comments. I want to thank all of you for tuning in and attending over your lunch hour, and apologize for those technical glitches that we had encountered. Very patient audience. Thank you very much. So thanks for attending. We will email the results of the polls that some of you missed, along with the evaluation for the webinar. Please send us your suggestions so we can improve these offerings. And we've just booked our next presentation, September 12th, also during the noon hour. Dr. Bonnie Purcell, who led the team that created, and this was mentioned earlier in this discussion, the Senior Alcohol Misuse Indicator, the SAMI tool that some of you are familiar with. a senior-friendly approach to screening for alcohol use in older adults. So stay tuned. Some registration links will be on their way approaching that date, and we hope to see you again. I'm Ken Wong, again, on behalf of the team at the RGP. My email address is there if you'd like to get on the mailing list and receive information on these events. But without any further, and there are a lot of people saying thank you, we'd like to thank the audience and also thank Drs. Mehta and Dr. Krause for making time out of their busy clinic schedule, being the last year of their training, to present a very enlightening topic and confuse us even a little bit more on the topic of screening and the evidence surrounding it. Thanks everyone for tuning in. We will send a recording and slides out and catch you up on the polls, and we hope to see you again soon.